introduction of this. I would like Dr. Ajit. I think he doesn't need any introduction. He's known all over in India in the field of critical care with his vast knowledge and experience.
Loud, I believe.
You're not able to hear me, sir?
Dr. Rajwardhan, the voice is not adequately loud, I believe.
Okay, fine.
Can you come
Anyway,
near to the speaker or something?
Yeah. Anyway, my role is not that much. It's both you and Dr. Raghavendra's. I'll invite Dr. Ajit. He definitely needs no introduction. He's known in the field of critical care in India, for his experience as well as his knowledge. Okay. I'd let Dr. Ajit take over the session and let him go ahead and do it.
Yes. So can we start?
Sure, sir. We can start, sir. Am I audible?
Can we start?
Yes, sir. Yes. We can start, sir.
Yes. You are audible. Yeah. So okay. Good evening, friends. I would like to thank Dr. Deshpande and Dr. Rajwardhan for giving me an opportunity to be here. And I can see that we have 4 topics are there today. And one is about hypertonic saline and mannitol. The second one is about the ventilator-induced diaphragmatic dysfunction. And the third one is about vitamin C and thiamine. And fourth one is about IABP, indication, contraindication, and complications. So we are directly going to IABP now?
Yes, sir. Yes, sir.
As for the brochure, just the hypertonic saline. Yeah.
Dr. Faisal has his duty, it seems. He has some commitments.
Yeah, that's
so he has
fine,
requested us.
Yes. So the first topic that we are dealing is about IABP, indications, contraindications, and complications. I invite Dr. Faisal Qureshi. He's an MD in anesthesia from PJ Chandigarh and GM in critical care from AIMS Jodhpur. I request Dr. Qureshi to start the session.
Okay, thank you, sir. And good afternoon, all. So my topic is IABP. So what I have done is, especially for the exam goings, I have prepared some objective slides, and I have also given a brief the mechanics and working of IABP in this. And at the end, the last slide I have included like what will be your approach to the question if it is a 10-marker question. So I have included those slides. So you can skip the rest part and just look at the for the revision purpose those objective slides. So I'll begin.
Yes.
So coming to the introduction. So what is IABP? So basically,
not believing only clinic, that plus symbol activity.
Hello. Yeah. So basically, it is a circulatory assist device to support the left ventricle, failing left ventricle, and it uses a counter pulsation where aortic blood is displaced along with the periodic inflation and deflation of the balloon. Now this balloon is connected to a console which dictates the inflation and deflation with the passage of a helium gas. Now this inflation and deflation is controlled via console. So what you see on your screen is the IABP console. Now it has a various waveforms which I'll discuss on later, and it has certain numbers on it. So which I'll go in details. So what does the IABP do? So basically you see on the right side of there is an image. So during the systole, the aortic valve is open and the balloon is deflated. So but sudden deflation of the balloon causes a vacuum-like effect, which helps the LV in increasing its cardiac output, and basically it is causing a decrease in afterload and a decrease in cardiac work because the afterload is reduced, and which in turn ultimately causes decrease in myocardial oxygen consumption. And now coming to the right side of the image, you see the balloon is inflated. Now this inflation of balloon causes the increase in coronary perfusion. So by increasing the aortic end diastolic pressure and decreasing the LV end diastolic pressure, it increases the CPP, coronary perfusion pressure. Now these 3 waveforms I'll discuss on later. So this is the basic mechanics of IABP. So it increases coronary artery perfusion, it increases oxygen supply, it increases myocardial work by reducing afterload, it decreases the oxygen demand, it increases the blood pressure, and also indirectly it decreases the pulmonary artery pressure. because by unloading LV, it causes a decrease in pulmonary artery pressures. Now, about the catheter of it. So the usual length is around 22 to 40 centimeters, out of which the bladder is 10 to 20 centimeters long. And you see the cross section of the bladder over here. One second, Lisa. In the cross section, you can see there are two lumens. One is for the helium balloon and one is for the blood lumen. So the blood lumen is transduced to the pressure transducer, and it gives the aortic and diastolic aortic pressure waveforms. And the helium lumen is for the rapid inflation and deflation of the balloon. Now the optimal size is that 85% of the aorta should be occluded. Although practically this is not done usually, the size is selected based on the height of the patients. So this is the balloon, this is the cross section, and this is connected to a console, and this is the helium cylinder. So as I mentioned, the IABP balloon is selected on based on the height. So most common size used in clinical practice is 40 cc, which is 5 feet 4 inches to 6 feet. And also it is available in pediatric sizes. Now this is the IABP console, and the numbers over here represents, like, the first number is the heart rate, and the next two numbers are the systolic and the diastolic blood pressure, and this is the mean arterial pressure, and the number written in the white color is called the augmentation. So what is basically the diastolic augmentation? And these are the ECG waveforms and the IABP waveforms and the inflation and deflation waveforms. Now coming to the counter pulsation effect. Now this slide is very important, as you have to draw the diagram and label it very accurately in the exams. So kindly focus on this slide. Like, this is the B point represents over here the unassisted aortic and diastolic pressure, and C is the unassisted systolic. Now over here the inflation is occurring. Now you see, as soon as the inflation, there is a sharp V forming, and the D point is the diastolic augmentation, which should be higher than the C. And then after that, there is deflation occurring, and which is the occurs at the end of the diastole before systole, resulting in reduction of aortic and diastolic and systolic pressures. So this is the normal appearance of a IABP waveform. Now we have already discussed the effect of inflation and deflation, so I'll not read it again. Now this slide is giving the perspective along with the coronary perfusion. So you see at the point D, there is increased coronary perfusion. So this is occurring at the late diastole. So when the balloon is inflated, the blood flows into the coronaries, and there is increased coronary perfusion. Now if you see at this diagram, the balloon is deflated, and the balloon is deflated, and it causes better LV output and increase in the stroke volume. So this point corresponds to the E point over here, reduced myocardial oxygen demand. Now, after you have inserted the IABP and you see certain waveforms like we discussed. So there are three types of waveform visible over here. So first is the ECG, second is the aortic, and third is the balloon inflation and deflation. So how to check it? So you cannot check in 1:1 pulsation. You need to decrease the pulsation from 1:1 to 1:2. So that one is the original patient's waveform, and one is your supported. So 1:1 basically means that all the beats are supported by the IABP, and 1:2 means every alternate beat is supported. So after that, you need to check the dichrotic notch and see that if augmentation starts at the V point. So this is the point we are talking. So there should be a sharp V, and check if the diastolic augmentation is higher than the unassisted systolic wave. So we see the diastolic augmentation is higher than the unassisted systolic over here. Now, regarding positioning, the balloon is positioned. The end of the balloon should be just distal 1 to 2 centimeter from the left subclavian artery, and this can be confirmed either by fluoroscopy over here or by the chest X-ray. Chest X-ray, the usual is it should be about 2 centimeters above the carina. So this is the standard marking of the IABP. Now, this slide is important in clinical practice because the IABP requires accurate inflation and deflation of for its proper augmentation and proper support. Now, although the latest IABP have a auto mode, so which usually takes care of all these errors with the timing, but still you should be aware. So the first is, so the first you can see the inflation is occurring before the dichrotic notch, before the dichrotic notch. So it is early inflation, and it causes a result in aortic regurgitation because the aortic wall is still open, and it causes in fact increase in LV ATP and increase in myocardial oxygen demand. The second B slide, you see there is the inflation occurring after the dichrotic notch, and you see the diastolic augmentation is suboptimal. Over here, the systolic, unassisted systolic is higher than the diastolic augmentation. So this is late inflation after dichrotic notch. There is absence of a sharp V, and there is suboptimal coronary perfusion in this. Now next is early deflation, because you see a sudden rise, sudden fall in the diastolic slope, and it leads to again retrograde coronary flow, and it again causes suboptimal diastolic augmentation. And the last one, you see there is a late deflation because of a widened appearance, and the systolic rise is also very obtuse or very slow, the prolonged rate of rise of assisted systole. So there is a rate of assisted systole is prolonged, and afterload reduction is completely absent in this, because now the LV is pumping against a inflated balloon. So basically afterload is increased in this case, and which in turn causes increase in myocardial oxygen demand. So these are the same slides. So if you want to read in detail, I have put over here, but these are the same things which we have discussed. Late inflation, early deflation, late deflation. Now coming to the indication. So as of now, there are no hard evidence or there are no convincing evidence for IABP insertion. Although in the past there have been certain trials, but as such, there are no class 1 indications for these IABP. So mostly no choice indication when you have a no choice. So these are the like failure to come off bypass. Certain patients who are in the operating room, they are not able to wean off. We are not able to wean off. So in those cases, basically it is indicated. And also in certain acute MR due to ischemia or MI,
Understood.
ventricular septal defect with hemodynamic compromise. Now, IABP will always act as a bridging therapy, and it's not an end result. So, the IABP can give surgeon some time for the patient to get stabilized. So, that is one indication of IABP. Others are probably harmless but also not useful. So these are the high risk CABG patients, high risk PCI patients, cardiogenic shock while waiting for PCI, and again pulmonary edema due to cardiogenic cause in spite of maximal medical management. Now others experimental are like certain authors have published certain case reports. So though in those the IABP has been used, such as Takotsubo cardiomyopathy, neurogenic stress of cardiomyopathy of SAH, and severe aortic stenosis. It's getting hanged again.
Qureshi,
Okay.
you are
Yes, sir. So the guidelines I am showing to you over here. So these are the latest 2020 European Society guidelines. Now for the management of without ST elevation patients. So they have included a IABP insertion should be considered in patients with hemodynamic instability or cardiogenic shock due to mechanical complication class 2A. And the previous guidelines like 2014 AHA with non-STEMI is IABP counter pulsation may be used with non-STEMI to treat severe persistent or recurrent ischemia, especially in patients awaiting invasive angio or revascularization. So again, it is used as a bridging therapy until the patient is shifted to cath lab or the OT. So, classical indications are acute left ventricular failure post cardiac surgery, severe unstable angina, cardiogenic shock post MI, or bridge to cardiac transplantation, and stunned myocardium after myocardial infarction. Now, obviously, when a balloon of certain length is inserted inside the aorta, it is not without the complications. And the most common complications reported in the literatures are mild ischemia, like 2.9%, or major limb ischemia requiring discontinuation of the support is around 0.9%, and balloon leak is 1%. So balloon leak will is very devastating, and because the helium will directly leak into the systemic vasculature, so it can cause embolism. And another are a hemorrhage 0.8%. So if you see, the complications are very low compared to the other mechanical devices. Now, coming to the weaning, the timing of the weaning is important. The patient should be stable for 12 to 24 hours. And so what we need to is there should be a decreasing inotropic support. And what we need to do is just, decrease the pump ratio. So if you see this video, in this we are decreasing the pump ratio from 1:1 to 1:2. So you see the support is now changing alternate beats, and now the support is reduced 1:3. So every third beat is now supported by IABP. Yeah. So during decreasing of the support, we need to monitor the patient from like what we used to do in ICU. So lactates, urine output, and the temperature of the patient, and blood pressure, inotropic support. So everything is monitored closely. And if the patient becomes hemodynamically unstable, weaning should be immediately discontinued. Now there are certain absolute contraindication for the IABP, such as absolute include a severe significant aortic regurgitation, because IABP will in fact increase the regurgitation jet in this, because when it inflates, the jet will cause more of regurgitation. Aortic dissection, aortic stents, and bilateral femoral popliteal bypass for severe peripheral vascular disease, because the insertion site is femoral artery. Others are relative contraindication, such as abdominal aortic aneurysm, uncontrolled septicemia, uncontrolled bleeding, and severe peripheral vascular disease. Now, these are the points which we need to keep in mind practicing IABP on patients. So, such as basically the IABP works on the mechanism by increasing the oxygen supply, myocardial oxygen supply, and decreasing the oxygen demand. Now, when after inserting, when there is a decreased urine output after IABP, then it can be due to juxta-renal position of the pump, and it requires repositioning of the IABP. The hemolysis can occur which can reduce the hematocrit to 5%. Suboptimal inflation and deflation will lead to hemodynamic instability, and the IABP is thrombogenic and it requires anticoagulation. Never switch off the balloon while in the patient because either we need to use it or we need to remove it, but we cannot switch off. IABP effects basically depends on the heart rate, because increasing heart rate will lead to decrease in the efficiency of the IABP and decrease in diastolic augmentation, diastolic time, and the balloon volume and the aortic compliance. Because the diastolic augmentation is a property of aortic compliance, the aortic recoil. So I have finished my presentation. Now, just for the time constant exam questions about IABP. So what we need to do is give a brief introduction to IABP and what does it do, and draw a diagram of normal counter pulsations with accurate labelings. And we need to remember that the diastolic augmentation is higher than the systolic peak, unassisted systolic peak, and will decrease the aortic and diastolic pressure, its beneficial effects, insertion techniques, and confirming how to confirm it. And then we need to list the indication, contraindication, and complications, and the weaning method. And for Viva, we also need to have certain knowledge about the timing errors. Thank you, sir.
So thank you, thank you, Dr. Qureshi, for
Thank you, sir.
the excellent, short review about IABP. And I think you have mentioned everything. See, the indication for IABP, obviously it is causing, the reduction of the afterload, diastolic augmentation, all these things. Obviously, it works by the mechanisms. But the indication of the IABP has been, kind of evolving slowly, over the last, maybe around 10, 15 years or so. See, what is happening is that previously for every cardiogenic shock and myocardial infarction, cardiogenic shock, people used to routinely, regularly used to use an IABP. But, after the landmark trial, that IABP shock 2 trial, it has shown that in patients with the myocardial infarction with cardiogenic shock, who is going for a rapid early revascularization procedure, the use of IABP, patients who used treated with IABP and patients versus who are not treated with IABP, the outcome were the same. So there was no clinical benefit, was not really convincing, that for regular use of IABP.
Yes.
But at this point out, I would like to say that myocardial infarction with severe cardiogenic shock, and you can still use an IABP. Maybe it under the impression that it's going to increase the blood pressure of the patient, though it may not be the case all the time. And second thing is obviously, as you rightly mentioned about the mechanical complications after the myocardial infarction, especially when you have a severe acute severe MR, you have VSD, acute ventricular septal rupture and perforation. In those cases, mechanical complication as a bridge to definitely therapy, you can use IABP. And obviously, all other things, experimentally it has been used. And second thing is regarding the right efficiency of IABP. So all of the students and all of the listeners should be thorough with IABP, the waveforms and all, because once in a while you peep at that, means you may remember that, and unless you work on a daily basis or you see and interpret on a daily basis, you may not be able to identify that. One thing which can increase the efficiency of IABP is very important thing is the timing of an inflation and deflation. That is very, 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 very important. The timing of inflation and deflation. Other thing, the type of assist you are giving. You are giving 1:1 assist or whatever, the less assist. Third thing will be the heart rate. As Dr. Qureshi has mentioned, when the heart rate is more than 130 minutes, the efficiency definitely decreases in increased heart rate. And when the cardiac index is too low, if it is less than 1.2 to 1.4 liter per minute per meter square, these are some of the things, which, in those conditions, the IAP may not be that useful. So those things are very important with efficiency. So coming to the contraindication, Dr. Qureshi has already mentioned, obviously severe, AR, we will not use, dissecting aneurysm, aortic processes. Some mild variation will, if you look at the literature, some mild variation will be there. Some literature which I went through was showing some PDA, patent ductus arteriosus, the contraindication. Sometimes we have an aortic graft which is less than 12 months or something. I vaguely remember something that's also such to be a contraindication. Severe peripheral vascular disease may be a related contraindication. So these contraindication has to be there. And obviously, the most important thing is that whatever indication you're using should be a reversible thing. You are looking at a definite care immediately or later. you're going to have, that's very important. These are the contraindications. And the complication, as you said, obviously, because the ischemia is there, because some of the literature is telling even up to 20%, maybe large vessel, small vessel ischemia, we can divide, the hematoma can be there. Sometimes you can develop, some kind of AV fistulas, some pseudoaneurysms are not uncommon. If you look at the literature just for reading point of view, you can have, as you said, the bowel ischemia, spinal ischemia, all these peripheral neuropathy, these are all not there. Sometimes entrapment of the IABP, you are unable to take it out, can happen. And during insertion, the position of the IABP is very important. Dr. Qureshi has already mentioned. While we inserting, we have to see that it is above the renal artery. It is distal to the left subclavian artery. That's very important. The tip has to be there. It has to be distal to it is the distal from the heart, from the distal to the left subclavian artery. If it is 2 inch, you can have, the limb ischemia can be there. So obviously it has to be distal. And it has to be above the renal arteries as well. It's very important for, not to be affected renal dysfunction. So that's the thing. So it all depends. People who work in the cardiac critical care unit, maybe, especially, the cardiothoracic unit may be a routine thing to see. But, you need to go through that on a daily basis, so that you can be thorough with, these discussions. Dr. Raghavendra, anything is there?
No, sir. No, sir. You have detailed it about. And one more thing is that the routine. What is your take on utility of IABP on extracorporeal devices like ECMO? Whether is it beneficial? Because what they say is that it sometimes since the extracorporeal return cannula, return limb will have a continuous flow. IABP when inflating may obstruct the flow. What is your take on this, sir?
No, because I'm not a real expert on that. I know it's a kind of a controversial thing, so I don't want to comment about it honestly.
Yeah.
Yes.
Sure.
So my Dr. Qureshi has mentioned, I think severe aortic stenosis, I think some kind of experimentation is happening. Am I right, Dr. Qureshi? You use,
Yes, sir.
ECMO with, veno arterial ECMO along with, IABP.
Yes, sir. Because basically it works by decreasing the afterload in aortic stenosis, and the usual management during anesthesia also, a line of management is to decrease the afterload. So, so why not? Some people have tried this aortic.
So any questions in the chat box? I can't see any questions, but post questions here. Yeah. Yes. Can we go to the next topic?
Yes, sir. We can go to the next topic, please.
Yeah. So who is
I'll start sharing, sir. So I have stopped the sharing screen, sir. Now the next person can continue.
Dr. Shabrish,
Hello.
sir? Yeah, Dr. Shabrish.
Yeah, is my screen visible?
Yes. So sorry. It is your name is visible. Sorry.
Okay, sir. 1 second. Sir, is it visible now?
No, we can see your name. That's all. No slide. Your PPT is not visible.
Okay, 1 second.
Yes, now we can see you.
Just seeing how to share this screen. 1 second.
So there is an arrow mark is there upwards, pointing upwards at the bottom of your screen, share screen.
Yeah, share screen is there already done, sir, actually.
Yeah.
It's
Then you
ticked
keep it
also.
open. Your PPT need to be, you can keep it open in your, whatever the screen. Then
Yeah, it's open now.
automatically.
Can you see now?
No, we can't see.
Dr. Shagdish, you can share the entire screen of your laptop.
Okay. See, on. Okay, 1 second. Now?
No, Dr. Shagdish, we are not able to see you.
1 second.
So you can keep it open your screen, main screen, your entire PPT. Then you come to the share screen and just click on that.
Okay, sir. Yeah. Okay.
Now,
Yes, yes, it is visible, Dr. Shagdish.
Okay.
yes, now it's there. Yeah. You have to enlarge that. Yes. Yes.
Now it's visible, right?
Yes, yes, yes.
Yeah. Good evening, sir, and good evening, all. So today we'll just discuss in brief about mannitol and hypertonic saline. They can be asked as a 10-mark question, or you can as divided into comparison of mannitol versus hypertonic saline in a specific situation, such as introduction of raised ICP alone as a 5-mark questions they can ask, or you can have each drug as for 5 marks each. Okay. So moving on, first we'll talk about mannitol. Mannitol, it is a 1 to 6 hexanol, which is a naturally occurring polyol, which is largely employed for this osmotic diuretic characteristics. It mainly acts by it's a osmotic diuretic. Main purpose, which is widely used across for reduction of raised intracranial pressure. How it reduces the raised ICP is by raising the intravascular osmotic pressure, which draws the extra into the intrament. And then this rise causes a rise in the plasma volume, which initially reduces the blood viscosity and thereby increasing the microvascular blood flow and increases the tissue oxygenation. So increased tissue perfusion causes a reflex vasoconstriction and thereby reduces cerebral blood flow to the brain and thereby lowers the ICP. Following the other mechanism of action of mannitol is in the renal as well as the free radical scavenger and reduction in the oxidative stress. In the renal system, it reduces the osmolarity of the glomerular filtrate because it freely crosses across the tubules and it doesn't get reabsorbed. And thereby, it increases the urinary volume and removes gas and increases prostaglandin, vasodilatory prostaglandins, and reduce renin in the distal tubules, thereby causing vasodilatation and increase the renal blood flow. So these are the mechanisms of action of mannitol on different body parts. So pharmaceutics, it's actually a sterile, available as a sterile solution in 10 to 20% in water, weight by volume in water. And osmolality is around 1,100 milliosmoles per liter. And for the reduction of raised intracranial pressure, it is given at a dosage of 0.25 grams per kg over 15 minutes. Up to 1 gram per kg dose can be given. And the onset of action is within a few minutes, and duration is from minimum of up to 3 to 6 hours. Absorption 20% absorbed if you given sorry, it's IV, and volume of distribution is 0.5 liters per kg, and it is not metabolized in the body, and elimination is clearance rate is 7 ml per kg per minute with a t half of around 72 minutes. So indications, as we had already mentioned, it is mainly used for reduction in the raised ICP and preservation of renal function during perioperative period in jaundice, previously used for even patients with rhabdomyolysis within the first 6 hours, and patients undergoing major vascular surgery such as CPB, etc. And acute management of glaucoma, where through the osmotic effect, it tries to reduce the raised volume of the vitreous humor and thereby reduces the intraocular pressure in the glaucoma, and to initiate diuresis in a transplanted kidney. So these are the main indications. So the adverse effects of mannitol, they include hypovolemia uh, by volume depletion and due to osmotic diuresis. The initial hypervolemia, which is caused because of water extraction from the interstitium, may cause pulmonary edema and precipitate hypoxia in patients with cardiac failure. Aggressive diuresis can precipitate hypovolemia, as we have discussed, and it washes out the medullary interstitial gradient and thereby decreased ability to concentrate urine. And hypokalemia and hyponatremia are the dyselectrolytemias associated with hypertonic saline, and it should be discontinued if sodium is greater than 160 or serum osmolality is greater than 320 milliosmoles. Otherwise it can it is also can cause central pontine myelinosis. Rebound increases in ICP can occur after the initial reduction because of eventual passage of mannitol into the brain. One thing to be noted about mannitol is that it works well only when the works best when the blood-brain barrier is intact and the cerebral autoregulation is maintained. The quality of both these things, the blood-brain barrier as well as the cerebral autoregulation, is doubtful in a traumatic or non-traumatic brain injuries. So this is about mannitol. So moving on to hypertonic saline, it is nothing but supraphysiological quantities of sodium chloride with varying concentrations, and the vehicle of delivery is through diluted in water. So you can see the different concentrations of saline available: 0.9% to 7.5 up to 23.4% of saline. And you can see the osmolality gradually increases from 308 to 1027. The commonly used ones we use were 3% saline for clinical and anticipated clinical benefits, and routine resuscitation fluid is 0.9% saline. Though the higher the concentration, the more is the osmolality. So how does hypertonic saline work for raised ICP? It works by establishing a gradient, osmolar gradient between the intracellular and intravascular spaces, and thereby it has some rheological effect and causes a biphasic reduction in the ICP. So fluid moves osmotically from the intracellular into the interstitial space and then into the intravascular space. The agenda must be that the administered hypertonic saline must remain in the intravascular space and should not cross the blood-brain barrier to sustain the osmotic gradient. And there is proof that it has both neurohumoral and vasoregulatory effects in animal studies. And in the context of vasospasm, it may also operate as a cerebral vasodilator. And it has also shown that medical treatment resistant ICP, that is osmotherapy, the raised ICP, which is refractory to osmotherapy with 20% mannitol, has responded to hypertonic saline. And when it is utilized for patients with polytrauma, where there is a hemorrhagic shock along with traumatic brain injuries, there is benefit of improved survival was noted while using hypertonic saline as a potentially reversible. Hypertonic saline was used for both volume resuscitation and reduction in the raised ICP. So how it is administered? It is administered as a bolus or a continuous infusion at dosages of 1 to 4 ml per kg in the concentration range of 3% to 23.4%. And administration of hypotonic saline needs to be taken into account in patients with chronic hyper or hyponatremia, because a rapid escalation in sodium level, serum sodium, can precipitate CPM. And there's a close sodium monitoring is needed for these patients. So how does hypertonic saline act on the other body systems? In the vascular system, it causes increase in the intravascular volume and reduction in the edema formation. In the heart, it increases the mean arterial pressure, stroke volume, and also the cardiac output. Electrolytes and osmolality, it causes a transient rise in the serum sodium and and chloride levels, as well as the osmolality, which are usually reverts back to normal. And in the immune system, it as we have neurohormonal regulation, as we already mentioned, in the animal model it is found. And in renal, it causes reduced urine output in healthy volunteers and increased output in volume overloaded or overfilled patients. And perioperatively, previous older studies where it was used as an alternative for fluid resuscitation with colloid, the other commercially available colloids around 20, 30 years ago, it has shown to reduce mortality, ICU number of ICU days, and ventilator days. So the reason for using the hypertonic saline long time back was because it was relatively inexpensive and rapidly available, and there was no risk of anaphylaxis compared to the human albumin available during that time. But it is no longer used for plasma volume expansion purposes. It was also used for studying critically ill patients with shock, such as hemorrhagic shock, cardiogenic shock, and in burns. But the patient-centered outcomes were not well validated, so it is no longer used. And this is about the usage of hypertonic saline. So hypertonic saline for nebulization, we see sometimes they use in ICU, especially for COPD patients and bronchiectasis patients. There have been in vitro research where hypertonic saline has shown to disrupt the biofilm formation by Pseudomonas, and also reduces the virulence factors with the associated organisms. And it is also appears to reduce the level of protective against the oxidative injury by production of glutathione and thiocyanate in the airway liquid surface. So hypertonic saline nebs have been we have been used. I mean, I think most of them used for the nebulization alpha as well. So advantages of hypotonic saline, there is rapid effect with a peak effect reaching within 10 minutes and lasts for around 1 hour. The thing is, unlike the mannitol where you give it as boluses and give it with the frequency of 4 to 6 hourly, here usually we keep it as a bolus infusion with a target sodium of 145 to 155, which you can repeatedly easily monitor via blood gases or the lab levels. And the first rapid effect is achieved by giving a bolus dose of around 100 to 200 ml stat. And it is less likely to produce hypovolemia as compared with mannitol. And there is rapid restoration of intravascular volume and blood pressure and reduction in the ICP. And it has a better effect on cerebral blood flow for a given reduction in the ICP. And it can be used as a continuous infusion and doesn't need a osmolality testing. Anti-inflammatory effect as demonstrated in the animal studies. So disadvantage, obviously the hypernatremia, as we already discussed about CPM, hyperchloremic acidosis and renal failure, need for a central line. Both 20% mannitol as well as hypertonic saline need a central line access because of their high osmolality. They can cause phlebite. Both agents can cause phlebitis and tissue necrosis if there is extravasation. Hypokalemia and lack of outcome data, which I will discuss in brief about the evidence of both the agents in the next coming slides. And increase in the circulating volume in case of cardiac failure patient, it can precipitate cardiac failure in borderline LV function patients. Coagulopathy, also there is no proven theory. I mean, it's all both cardiac failure and coagulopathy is all theoretical rationale where it can affect the APTT INR and platelet aggregation. Rapid change in the sodium may result in seizures and encephalopathy and rebound intracranial hypertension. And there is some non-specific data that it suggests that it can affect the normal range more than the injured and may worsen the herniation. So these are the anticipated disadvantages of hypertonic saline. So moving on to evidence, evidence actually now there are most of the lot of pitfalls of the evidence regarding hypotonic saline and 20% mannitol for management of raised ICP or translation of reduction in the raised ICP to mortality benefit or morbidity benefit in patients with either traumatic or non-traumatic brain injury is that most of the data is incomplete, or the study population is less, or they are based on either case series or retrospective cohorts, and there is a lot of crossover of the patient population also. So I have just taken two recent meta-analysis published, one in IGCCM recently in June 2024, where they have compared for non-traumatic brain injury role of osmotherapy. They've seen the efficacy of intravenous 20% mannitol versus 3% hypotonic saline in reducing in ICP in non-traumatic brain injury. So non-traumatic brain injury is basically insults due to stroke, abscess, encephalitis, obstructive hydrocephalus, metabolic encephalopathy where there is cerebral edema, or hepatic or uremic encephalopathy. This is with a reference to the non-traumatic brain injury. So in this, they have come across around 132 articles, and then they have screened down and included only 14 for analysis because of insufficient, I mean, because of the pitfalls in the other data. And they have come to know that they have shown that the interpretation of though the interpretation of primary outcomes varied across the different studies, they have shown that hypotonic saline has been in most of them, or most of these 13, 14 studies, they have shown that efficacy of hypertonic saline is superior to mannitol when it has come to reduction in the ICP. While few of them have shown that there is neither significant improvement between both, or there is a significant improvement, nor similar, or there is similar effectiveness between both the interventions. The secondary outcomes, such as number of duration of coma hours, reduction in mortality rate, restoration of cerebral perfusion pressure, and changes in the intracranial hemorrhage volume, also could not be valuable data is there, but then it cannot be extra. It is not a large scale RCT where it can be the findings can be extrapolated to the normal. I mean, for long term. I mean, for the day to day clinical usage. So in this, they have found that 7.5% hypertonic saline is superior to 20% mannitol, and males were more frequently affected than females with increased intracranial pressure. Both had a similar rate of complications, but no serious adverse events have been reported in either of the medications. So basically, safety profile is not there for both the patients, both the drug groups. So moving on to osmotherapy in traumatic brain injury, it published in 2017, sorry, where they have compared equimolar doses of mannitol and hypertonic saline. This also they have not narrowed down many this one research papers, and then narrowed down to the last seven, where they have even compared uses of if you see the 2005 research, they have used even dextran and hestrel as a this one solution in IV fluid that was used for during that situation. So here also both have showed to reduce the ICP, but which is more effective is still a matter of debate. And results that though hypertonic saline may theoretically have more be effective than mannitol for reducing ICP. The serum osmolality is not different after the treatment in both the drug groups. So the limitations of this in this meta-analysis, they show that there was a number of patient population was small, as we already told, and the other factors that which can potentially affect the ICP, such as use of vasopressor, blood pressure target, volume status of the patient, all this was not documented properly, and the concentration of the now hypotonic saline used varied across the population. One is 7.5, the other is 23.4 and 3% was used during more the situation. So none of these studies showed that an adequate control of the ICP had translated into a good neurological outcome. So this is about the use of osmotherapy in traumatic brain injury. So that's it about both the drugs.
So thank you, Dr. Shabri, for the excellent presentation. Uh, yeah, so that's the thing. So basically, we're talking about the osmotherapy. So, these agents, what is going to happen is going to increase osmolality of the extracellular space in extracellular environment. So naturally, because of the fluid is shifting from the intracellular to extracellular thing, and you are getting some kind of decreased, the size of the brain is going to be,
Brain
it is going to be
tissue.
shrunken. That's what's happening. So basically, if you rightly said, see, if you look at all the meta-analysis, whether it's a traumatic brain injury or non-traumatic brain injuries, so the only thing we can say is that there is no, if you look at the just ICP reduction, if you ask me for the ICP reduction, obviously normal saline is superior. But if you look at the mortality, there is no difference in mortality whether you're using normal saline or whether you're using mannitol. And so okay, mannitol, obviously there are certain differences other with mannitol and normal saline. See, mannitol, mannitol does not have any, for example, the sodium, it does not contain any sodium. Obviously, the normal hypertonic saline is, I mean, this hypertonic saline is around 530 milliequivalents of in a liter. The high sodium content is definitely there. Another thing is something called, the diffusion, the diffusion constant. I think diffusion constant actually. I think I'm just mistaken. So basically, so this mannitol can be, it is partially permeable, but the because it's around 9, the it's around 0.9. So basically for the hypertonic cell it's around 1. That means it's impermeable to the blood-brain barrier. Mannitol will be, mannitol is definitely, it is partly reasonably permeable. It is partly permeable to the blood-brain barrier. And the difference is that, as you said, if you ask me, because in our practice we used to use a lot of mannitol in many conditions. Nowadays we use a lot of normal saline. Maybe you can say that normal saline is much rapidly acting than mannitol. Maybe mannitol also rapidly acting. It is much more rapidly acting. We can say that. And obviously the thing is that when your patient is on a mannitol, you need to monitor. Ideally the osmolality. Osmolality need to be around 310 to 320 has to be there. The osmolality. So obviously there is no need to monitor the osmolality. You keep it around. Even you can just do an ABG. You can keep it between 145 to 155. That may be okay for that. But otherwise, all in all, I don't find that there is any difference, any clinical significant difference either whenever you're using normal saline or mannitol. Obviously, some theoretical advantage is that mannitol is known to reduce the the viscosity, some kind of rheology of the red cells and all. Even this can also cause. And on the other hand, normal saline is supposed to be having some kind of a intrinsic anti-inflammatory effect, but those things are theoretical. I don't think there's been proven of any benefit whether you use any of these things. So my take home will be that obviously when it comes to the mortality, that doesn't make any difference at all. But if you look at the ICP reduction, obviously it may be definitely in favor of a normal saline, 3% hypertonic saline, but it's going to make a difference. I'm not sure. And the thing is that 3% normal saline, see, usually sometimes hypertonic saline nebulization has been known to induce sputum using hypertonic saline has been used for for PCB detection, because you do the sputum, but if you can increase the yield, if you give a hypertonic saline, you can make the patient cough more vehemently. You can definitely increase the yield. That is one small thing which I can add to that. And a couple of questions are there. Dr. Raghavendra, you can take the questions. Dr. Raghavendra?
Yes, sir. Yes, sir. Yes, sir. There is one question which I find sort of this thing. There was
Bolus
a
versus
question.
infusion strategies of 3% normal saline and 20% mannitol in raised ICB. I don't think so. It makes any difference.
Yeah.
Whether
So
you
why
do
does
that,
the
but
bolus of
usually
3%
when
in
you give a 3% normal saline bolus, in my practice, I give in 2-3 practical thing. When the sodium is too low, obviously, sodium is low and the patient is fitting. So there is no point, you cannot say that I will correct the sodium very slowly. Obviously, that's an indication, immediate indication. You give a 3% normal saline, 100 cc, you give IV, maybe in 5 minutes time, 5 minutes time only you'll give, and you try to prevent, the herniation, whatever is there. Second thing is in acute neurological deterioration, you have suspending herniation, you give a bolus. Otherwise, in traumatic brain injury, in my practice, whatever we do a bolus over 250 ml, normal saline, hypertonic saline, then around 50 ml per hour, we monitor the sodium every 6th hour, we keep it between 145 to 155, that's what we keep. And obviously, the concern is that if the patient's having a chronic hyponatremia, you need to, give the sodium correction of the 3% normal saline can be sometimes the rapid, raise in the thing can be harmful. Otherwise, I don't find any, we can just discuss, keep on discussing, but it's not going to reach any end of the thing, infusion versus bolus. And the second question is, why does a bolus of 3% normal saline cause transient hypotension? I'm not very sure, because my understanding is that some of the experimental studies in dogs are shown that I don't know the theoretical, any particular reason for that. Like, some in rapid, infusion of 3% normal saline has been known to cause some, in dogs, and some kind of hypotension used to cause. I'm not very sure about that. Aghavendra, if you know, you can add to that.
Yes, sir. Even that was kind of, I'm not sure of that, because why does the
Yeah.
3% should cause the hypertension initially? Even I'm
Some
not
dog
aware of
studies are
that.
there, I believe, but humans, I'm not very sure. It is very significant. I don't know about that. In CKD patient, is there a risk with 3% normal saline? No, you can give a small, small bolus. Definitely you can see, because you're worried about fluid overload. You're very closely monitored. If in the other way around, with the only problem, if you are quite unable to give any kind of a fluid because you are concerned about the fluid overload, or you're concerned about the lung, then the only option will be to go for dialysis. You might to correct through the sodium. Maybe you can, correct the sodium through dialysis. That's what I believe. Yes. One more new message. No center line. So basically, I want to say that there is no need for a center line, because even I used to believe that 3% normal center requires a center line. There is no need for a center line. Even I have seen a meta-analysis, some kind of a review meta-analysis telling that there is no, it doesn't make any difference whether you are going for a peripheral line, you get 3% normal center, you can very well give through a peripheral line. There is no need for a center line. Raghavendra has already answered, I believe.
Yes, sir. Yes, sir. I answered, but I just punctuated, put a stop.
No,
There is
so
no
I
need
want
for
to give
that.
a new message. I think people have to check it. There is a meta-analysis. There is a recent review as well. I have come across. There is no need for, maybe it's relatively new, but there is no need for a central. It can be given for a peripheral line. You can Google and see. That's what I want to add, and add the listeners to just go through that and see. What is the role of 3% normal saline and mannitol in post-decompressive craniotomy patient?
Yeah,
See, decompressive craniotomy means basically after the craniotomy, we see it's all the practice varies. Many places in UK, if you go for it's a craniotomy, a craniectomy. I just try guess that you are meaning both. Once you do the decompression, there is, within 24 hours, maybe on the same day, many places they do stop, but some of the neurosurgeons do argue that no, you give it at least for 5 days. The
It
practice in
actually
UK,
depends on the
once you do
institutional
the fixation,
practices.
there is no, you can stop it immediately.
sir, is furosemide and mannitol combination still being practiced? Just
I think we have seen doing that, but I don't know about the evidence part of the thing. It makes any additional benefit is very doubtful. Because both are going to, worsen the thing. You go to do diuresis. I think the creatinine is going to worsen more, I believe.
mm-hmm.
Sir, shall we go to the next talk, sir?
Yes. You just introduced one, yes. Yes, Dr. Raghavendra?
Yes, sir. Shall we go to the next talk?
Yes.
Dr. Abbas? Yeah. Dr. Abbas, we are able to see your screen. All you need to do is a slide share.
Hi, good evening, sir. Good evening, Raghavendra.
Yeah, good evening, Dr. Abbas.
Yeah. I hope you are able to see my slides.
Yes, you need to
we are able.
expand the slide, PPT.
Okay. Is it visible, sir?
Yes.
Okay. So good evening all. So in next 20 minutes, I'll be covering the utility of vitamin C and thiamine as per the recent evidence. So I went through a previous year DRNB and DM question papers. So when the Merrick's study came by Paul Merrick in 2017, and from then onwards, everybody started using vitamin C, thiamine, and hydrocortisone combination. So most of the questions started appearing from 2017 till 2020-22 when the Lovett study came. So the questions which were asked was first was the role of vitamin C, thiamine, and hydrocortisone in combination in sepsis. And a few question paper just mentioned HAT protocol. So people did not know what is HAT protocol. It's basically a combination of all the three drugs. And a few question papers mentioned only Merrick's protocol. It is all again same thing. And a few question papers have asked metabolic resuscitation. Basically, metabolic resuscitation involves use of the vitamins and micronutrients. So it involves vitamin C, thiamine, and selenium, zinc, and other micronutrients. So the covering vitamin C and thiamine might help in answering the question as well. So how to answer this? So first I have to write about the introduction about the what drug it is, a brief history if possible. What is the mechanism? What are the concepts and applications in the critical care and landmark trials, specifically for DM and DRNB critical care. So the question they have asked is use of vitamin C, thiamine with the recent evidences. So coming to vitamin C, it is also called ascorbic acid. So it was first discovered by James Lind. He noticed that few of the patients who had a poor intake, who had anorexia, so basically they developed weakness of the lower limb, gum swelling, gum bleeding, and there was a delayed wound healing. Then he came to know that there was a deficiency of the vitamin C. He started feeding them oranges. With slowly they started recovering and they started feeling better. So normal recommended daily dosage for the females is 75 mg per day, and for males it's 90 mg per day. So what is the mechanism by which vitamin C acts? It's basically antioxidant in function. So it acts as a radical scavenging system, and it acts as a cofactor for non-iron monooxygenases. So it is involved in synthesis of dopamine and noradrenaline. This is very, very important, which we are mostly interested in. And it also involved in hormone synthesis, iron absorption from the gut, and cofactor for iron and alpha ketoic acid dependent oxidation enzymes. So these enzymes are involved in collagen synthesis. That's why there is a delayed wound healing. Then carnitine synthesis, and these enzymes also involved in the expression of the genes and epigenetic erasers, as well as amino acid metabolism. This is the structure of the vitamin C. Coming to the mechanism most we are interested in. So in case of sepsis and septic shock, so most commonly they require, with a septic shock, we use norepinephrine infusion. The ascorbic acid or vitamin C is a cofactor for the tyrosine hydroxylase, which converts L-tyrosine to L-dopa.
Who is there in the night?
Eventually gets converted to
Thank you. You are there
dopamine.
tomorrow, no? Tomorrow you are
So
there?
from dopamine, the dopamine gets converted to norepinephrine in the body, which acts as an endogenous catecholamine and endogenous vasopressor. In patients with vitamin C deficiency, there's a lesser conversion of the L-dopa and dopamine. Eventually, there is a lesser norepinephrine. This is concept what initially believed that by replacing vitamin C in sepsis, if there is a deficiency, we can increase the level of norepinephrine. In fact, there might be an increase in the blood pressure and decreased requirement of the inotropes, and eventually the outcome was better. So it also acts as a scavenger. It restores tetrahydrobiotin and alpha tocopherol, and it preserves endothelial integrity and improves cellular function as well. Coming to other indications where vitamin C is indicated, commonly in case of ascorbic acid deficiency, that is in scurvy, the dosage recommended is orally from 100 to 500 mg daily, depending on the severity of the disease. Whereas in case of burns, for better wound healing, off-label route, it is 500 mg per day is recommended. Normally used in case of scurvy, it is 70 to 150 mg daily. In case of severe deficiency, you can go up to 3 gram per day dosage. Off-label other uses are methemoglobinemia, where if you feel there is a contraindication for the methylene blue in cases of G6PD deficiencies, you can use a high dose of vitamin C, that is up to 1 to 10 gram every 6th hourly until methemoglobin level normalizes. And the use of sepsis and septic shock we will discuss in detail. Coming to dosage, as I said, normal maintenance dosage in specifically who are very critically ill, 100 to 200 mg per day, you can use as a maintenance dose who are admitted in the ICU for a long period of time. In case of renal failure, if the eGFR is less than 30 ml per minute, then you can use less than 100 mg per day. Either you can use 75 or 80 mg per day. Coming to MERICS protocol, this was a landmark trial which got published in 2017 by a Paul E. Merrick. Basically, what he used was a combination of vitamin C, thiamine, and hydrocot in sepsis with septic shock patients. Vitamin C used was 1.5 gram 6th hourly dosage. Thiamine was used 200 mg BD, and hydrocot was used 50 mg 6th hourly. In this study, they found that there was a reduction in the mortality in the group. There was a reduction in the inotropic requirement, and there was a reduction in the SOFA scores after the use of all the 3 drugs, reduction in the procalcitonin, and there was an improved renal outcome. It's very, very important to know why vitamin C is used with the combination with the thiamine. Basically, what it does, especially when you use high dose vitamin C, it gets into the renal system. It eventually gets converted into the oxalate, and oxalate stones are formed. To prevent this, we use a thiamine as a supplementation. Basically, this vitamin C to oxalate cycle involves dioxalate to oxalate by the reduction method. So once we give thiamine, the glycosyl alanine transferase enzyme, this converts glyoxalate to carbon dioxide instead of oxalate. So there's a lesser production of the oxalate, and it prevents vitamin C toxicity. So after MERICS, there were multiple studies which came from 2014 to 2019, which showed that moderate dose use of vitamin C along with combination of the thiamine had some mortality benefit, and as well as reduction in the length stay. And few of the meta-analyses also during that period using these studies showed that there was a improve in the mortality. Eventually, when the evidence started evolving in 2019, there was another trial which came, randomized controls trial, multicentric trial, which is CITRUS-ALI. So CITRUS-ALI, so basically this was in 167 patients where they used vitamin C in the control arm. They used this vitamin C in patient with sepsis with ARDS. The inclusion criteria was more than 18 years of age, which involves sepsis with a septic shock and patient who had a ARDS. And their primary outcome was change in the organ failure by using a mSOFA score. They found that their primary outcome was basically baseline SOFA score. The baseline SOFA score was not significant. However, in the secondary analysis, they found that the mortality in 28 or 30 days mortality was significantly better in a vitamin C group. So with the MERICS protocol, with the CITRUS-ALI study, so people started using all the 3 combination of the drugs like vitamin C, thiamine along with the hydrochloride. Then, as the evidence allows, another trial came in, that is a vitamins trial in 2020. Basically, these used vitamin C along with hydrocortisone, and in control group, they used hydrocortisone. In their analysis, they found that there was not much of difference in terms of 28 days ICU mortality, length of stay, or 90 days mortality. So basically, this was a negative trial. Eventually, as the evidence evolved, there were multiple randomized controls trial, High Victor's trial, Orange's trials, ACTS trial, then ATTE's trial. These are all trials which eventually came where they used 1.5 gram of vitamin C every 6th hourly. These did not prove any improve in the mortality benefit. The latest trial which came, this was a study which was conducted in 872 patients. This was a multicentric RCT trial, which was the latest one. Basically, in this they included patient with sepsis with septic shock and where the vasopressor requirement is there. So their primary outcome was the composite death and the persistent organ dysfunction on the day of 28. Initially, in the MERICS protocol and citrusali trial showed some benefit. Eventually, the other trials like vitamins and oranges and ATES trial, they did not show any benefit in term. Whereas LOVIT trial, if you see the result outcome, in fact, instead of benefit, it showed that the mortality in 28 days mortality was bit higher in vitamin C group, 35.4% compared to a control group. So that's when everybody stopped using vitamin C along with the thiamine combination, thinking that mortality was higher in this group. Coming to this was a recent trial, LOVIT trial, which showed that in fact there was increase in the mortality with the use of the vitamin C. And there was one more trial which was ongoing during this point of time. This was a PETAL trial, that is prevention and early treatment of acute lung injury by using vitamin C. This study was stopped because LOVIT trial came and it showed that there was increase in the mortality. This also showed that there was a little bit increase in the mortality. So coming to other trials where vitamin C can be used, the vitamin C in ARDS and COVID. Initially, there were some trials which showed that there was a mortality benefit and there was a decrease in the length of ventilator requirement in case of ARDS and COVID-19. However, the results were inconsistent. The mechanism which was proposed was basically it is anti-inflammatory properties along with antioxidant properties, and there was a improvement of the collagen synthesis, and there is a preserving of the endothelial barrier along with the immunomodulatory effects. However, the results are very inconsistent. What are the other uses and ongoing research on the vitamin C? Recently, few of the studies in the cardiac surgery and burns shows that decreased the cardiac enzymes and improved clinical outcomes after the cardiac surgery, and decreased fluid requirement and reduced wound healing time, and in the hospital mortality after the burns. And vitamin C may also hold benefit in the management of the other ischemia and reperfusion injuries in the population where there is a post cardiac arrest and after a solid organ transplantation. Currently, covering the basal vitamin C requirement during the critical illness is recommended. However, high dose recommendation is not there. Coming to vitamin B1, that is the thiamine, we'll briefly cover about that. Basically, this vitamin B1 is a catalyst for conversion of the pyruvate to acetyl CoA. This is an oxidative decarboxylation reaction mediated by pyruvate dehydrogenase. Basically, this is a Krebs cycle which happens in the cycle. It's a very, very important part of the cell cycle. Where there's a conversion of the pyruvate to acetyl CoA by pyruvate dehydrogenase. Here, the vitamin B or thiamine is the cofactor. So usually vitamin D deficiency is seen in chronic alcoholism, where there is inadequate dietary intake, especially on rice tube feeds, malabsorption syndrome like inflammatory bowel diseases, and there is increased metabolic demand and prolonged starvation, and there is anorexia. Basically, how the thiamine deficiency presents is one is a Wernicke's encephalopathy. This is a triad of delirium, oculomotor abnormalities, and ataxia. Korsakoff syndrome is basically antegrade and retrograde amnesia and confabulation. The features include it can present as a heart failure, it can present as a mild confusion to a delirium, depending on the level of the deficiencies. It might add on to a critical care neuropathy. It might have a gastrointestinal dysfunction, and there is an unexplained lactic acidosis. Normally, the thiamine dosage which is recommended varies from 100 mg to 500 mg depending on the deficiencies. So thiamine can also cause deficiency of the thiamine can also cause unexplained lactic acidosis. How the mechanism works is basically glucose get converted into pyruvate. Pyruvate enter the basic Krebs cycle later on. If there is a deficiency of the thiamine, which acts as a cofactor at a pyruvate dehydrogenase, though the metabolism gets converted into instead of pyruvate going to acetyl-CoA, it converts into lactic acidosis. So there's increase in the lactate levels. So unexplained acidosis, you should always keep in mind that there might be a possibility of thiamine deficiency. To summarize overall, both thiamine and vitamin C have a specific indication. Initially, high dose of vitamin C was recommended. However, recent trials showed inconsistent results, and there are few trials which showed increased mortality. There was co-admission; it did not show much of mortality benefit. However, if there is any deficiency of these vitamin, definitely you should replace it. And if the patient who are on chronic ICU stay, we should use at least maintenance dose of both the vitamins. And a few recent studies in the cardiac surgery and burns showed that decreased cardiac enzyme and improved clinical outcomes after the cardiac surgery, and decreased fluid requirement and reduced wound healing time, and in the hospital mortality after the burns. Thank you. Sir, you're not audible, sir. You are mute, sir.
So thank you, Dr. Abbas, for the nice presentation. So at this point of time, whether especially in sepsis and septic shock, whether the vitamin C alone or in combination with thiamine, or thiamine alone or in combination with vitamin C, it has not been proved to make any kind of a clinical benefit at this point of time. And obviously, the initial trial was Merrick's trial. We all know, because it is a retrospective study, like a retrospective observation study, and a before and after study on a very small number of patients. If I'm not mistaken, I think it's around 27 patients have been in each group. It was there.
Yes.
And obviously, and the thing was that basically the expected mortality in the controls were high. So basically, it is the mortality in the treatment arm was around 8.5%. The control was around 40%. So that itself, kind of it has highly debated all the time. Now at this point of time, based on multiple RCTs and all, proved that it is of not much any significant benefit. You are giving vitamin C with or without the thiamine. In my practice, obviously we do that. Obviously, we all give it for this. People who are having a history of alcoholism, I expect a lot of thiamine. For the student purpose point of view, I want to add that there is another group of patients where people may require thiamine, is that people who are having a bariatric procedure, surgery procedures. After bariatric surgery, a lot of gastric bypass is happening. So naturally, the thiamine is basically absorbed from the duodenum. But what happens is that once you do the bypass, or even you do a gastrectomy, what happens is that, what I understand from the literature is that the choice of the patient's food changes. They develop some kind of affinity for certain food and all, which are really thiamine deficient. And these kind of patients, whenever you should have a low threshold to think about, thiamine deficiency, any kind of ataxia, because contrary to whatever people believe, the Wernicke's encephalopathy, you may not be having, ophthalmoplegia, encephalopathy, ataxia in all the patients. Some patients may be just an ataxia. So especially these kind of gastrectomy patient, those gastric bypass patient, bariatric surgery patients, there is obviously we need to open our thought for a thiamine deficiency. We need to see that they get it. And obviously TPN also we are expected to add on a daily basis, at least 3 milligram per day has to be added. Dr. Raghavendra, you want to add anything?
No, sir. This has been more of a controversial topic, I would say. This was a question when I was a trainee for my
I know.
third year.
Now I think it's all settled. The answers are reasonably clear now.
Yeah, definitely, sir.
True, sir. After 2022, there are not much of questions on this.
Yeah, the Lovit trial was the final nail in the coffin, I would say, on the utility of the thiamine and vitamin C in the sepsis and septic shock. What is your take on that?
Yes. I agree. So can we go to the next topic?
Definitely, sir. Definitely, we'll go to the next topic.
I think it's ventilator-induced diaphragmatic dysfunction. Dr. Divya Hiroli.
Yes, sir. Is
Hi,
my
welcome, Dr.
screen
Divya.
visible, sir?
Yes.
At the outset, I would like to thank my friend Raghavendra Deshpande and also Adit sir for including me in this academic session. My topic is ventilator-induced diaphragm dysfunction. So we'll see under these headings. First, what are the risk factors Then if a patient is having ventilator-induced diaphragm dysfunction, how is the outcome? And what are the different ways in which we can assess the diaphragm function in ICU? And also a small note on management and prevention. So what is ventilator-induced diaphragm dysfunction? Basically, patient is on a controlled mode of ventilation that leads to atrophy of the diaphragm muscle fibers. Thereby, there is reduction of the diaphragmatic contractile force. So now, why is the diaphragm function that much important? Because about 70% of the inspirative work is because of the diaphragm. So any diaphragm dysfunction can lead to significant weaning failure in the ICU. So etiology, the inactivity of the diaphragm muscle because of mechanical ventilation, this is the most important factor. And what are the other contributing factors which can increase the risk of patient going into ventilator-induced diaphragm dysfunction? One, if the patient is having prolonged hyperglycemia, if the patient is having malnutrition, significant organ dysfunction, if for some reason we have to give patients a prolonged neuromuscular blocking agent, if the patient is on a high dose of corticosteroids for a long time, or if the patient is having coexistent electrolyte imbalances, all this can increase the risk of ventilator-induced diaphragm dysfunction. So this is an article that was published in 2008 in NEJM, where they have shown that as little as 18 to 69 hours, that is about 2 to 3 days of mechanical ventilation, is enough to cause human diaphragm, atrophy of the diaphragm myofibrils. So what are the ways in which the diaphragm dysfunction can happen in a ventilated patient? One most important factor is if we are giving a controlled ventilation or excessive respiratory support, what happens is the diaphragm goes into, the diaphragm activity reduces. So in a normal spontaneous breathing, in a non-ventilated patient, what happens is the diaphragm contracts and the diaphragm gets pushed downwards. So the thoracic cavity increases, the pressure decreases inside the thoracic cavity and the inspiration happens. But what happens in a positive pressure ventilation is the diaphragm is passively pushed downwards because of the positive pressure ventilation. Actually, the diaphragm is not contracting during the positive pressure ventilation. So in case the respiratory support is high, if the patient is on a controlled ventilation for a long time, the diaphragm goes into a state of inactivity, and that will lead into diaphragm dysfunction. This is referred to as over-assistance myotrauma. This is one way. Second way, the patient say is on a pressure support ventilation. If the respiratory support is insufficient, what will happen is the patient's respiratory effort, the load on the diaphragm will increase significantly. So that can also cause myotrauma, that is referred to as under-assistance myotrauma. And any significant asynchrony in the ventilator, and also if we are giving excessive PEEP, that can also cause diaphragm dysfunction. So all of this can contribute to diaphragm dysfunction in a ventilated patient. Looking into the molecular pathogenesis, all these factors, invasive mechanical ventilation, the medication, sepsis, malnutrition, all of this will ultimately lead to increased oxidative stress. Because of this, what happens? There is increased proteolysis and decreased protein synthesis, and also calcium desensitization, because of which the muscle goes into atrophy and leads to ventilator-induced diaphragm dysfunction. So what is the outcome if a patient develops this ventilator-induced diaphragm dysfunction? It is very expected. The patient can have weaning failure, and because of this, there is increased duration of mechanical ventilation. And because the duration of mechanical ventilation increases, the length of stay in ICU increases, the length of stay in hospital increases, and it is also associated with increased mortality. Ultimately, the cost increases, chances of ventilator-associated pneumonia, delirium, and the requirement of sedation also increases. So how do we assess the diaphragm function in ICU? So bedside ultrasound techniques can be broadly classified into qualitative method and quantitative method. Qualitative method is just by eyeballing, and quantitative method, here we see the diaphragm excursion during tidal breathing and deep breathing. And then the second one is the diaphragm thickness fraction. Before we do diaphragm ultrasound, one important thing that we have to consider is the patient should be on a pressure support of ventilation and the pressure support should be as minimal as possible, preferably less than 5. What will happen if the pressure support is more? The diaphragm is passively pushed downwards because of the increased pressure support. Likewise, in the control mode, again, it is passively pushed downwards, and the assessment might not be right. So to get a right, real assessment of the diaphragm function, the patient should be on a pressure support ventilation, and the pressure support should be minimum, less than 5. So let's see how to measure the diaphragm excursion. For this, we use curvilinear probe, and it is placed just below the rib cage in the midclavicular line. And here, what do we try to see? We try to see the posterior part of the diaphragm along the with liver as the window. This is the shining structure is the posterior part of the diaphragm, and the beginning structure is the liver. With liver as a window, we try to see the posterior part of the diaphragm. So like I've already explained, what do we try to see? We try to see the excursion of the diaphragm during inspiration. So during inspiration, the diaphragm contracts, so it moves downwards. So, and during expiration, it goes upwards. So this excursion is what we try to measure during lung diaphragm ultrasound. So this is a video where we can see how to measure the diaphragm excursion. So this is the posterior part of the diaphragm with liver as a window. We try to see the posterior part of the diaphragm. We put M mode, and then we measure the height of excursion of this diaphragm. We take baseline, and then from the baseline, we take the height of excursion. So we get a waveform, something like this, and this excursion is what we try to measure. So when do we say the patient is having diaphragm dysfunction? If it is less than 1 centimeter, if the height of excursion during tidal breathing, normal breathing, not deep inspiration, because deep inspiration is difficult for us to assess in the ICU. During normal breathing, if the excursion is less than 1 centimeter, then we say the patient is having diaphragm dysfunction. Next, moving on to assess the diaphragm thickness fraction. For this, we use a linear probe, and we place the linear probe in the anterior axillary line. And anterior axillary line in the zone of opposition. It is important we understand what is zone of opposition. Zone of opposition is where the parietal pleura ends here and the diaphragm begins. So when we place the probe there in the zone of opposition, the diaphragm is identified like this: a 3-layer structure, 2 shiny white structure, and the middle hypoechoic muscular structure. The above one is the pleural reflection. This is the peritoneal reflection. This is the muscular part of the diaphragm. So we measure the thickness during inspiration, during expiration. So during inspiration, in a spontaneously breathing person, because the diaphragm is contracting, the diameter increases during inspiration, and during expiration, because it is getting relaxed, the diameter decreases. So the difference between this and the expiratory diameter into 100 is used for calculating the thickness fraction. So now let's see here. It is important for us to see the zone of opposition. The shiny structure here is the pleura. If we trace this pleura down here, we get the pleural reflection of the diaphragm. And the lower one is the peritoneal reflection of the diaphragm. Just distal to the pleural reflection, we place the M mode, and then we measure the thickness during inspiration and expiration. To reduce the intra-observer variation, inter-observation and it is ideal to take at least 3 readings for this measurement and take a mean of this reading and document it. So here, this is during inspiration, the muscle contracts and it thickens, and this is during expiration when the muscle is relaxed. So it is around 0.34 and 0.21 here. So if we put this value here, 0.34 minus 0.21 by 0.1, it gets around 66%. So when do we say the diaphragm is dysfunctional? If it is less than 30%, we say the diaphragm is dysfunctional. Another method is to see the tissue Doppler image. Not many studies have been done on in this. What we see is the excursion of the diaphragm during a sniff maneuver or a cough maneuver. And the cutoffs are not well established. If it is about 10 or 12 or 13, it is considered to be normal. Here in one of our patients, we have done this. We put a tissue Doppler image in the posterior part of the diaphragm, and we ask the patient to cough. And when we ask the patient to cough, we get an image like this. And this excursion of the diaphragm during cough can be assessed. Still, many studies are required to establish the cutoff points for this. But again, this can also be done to object activity during a cough mania. So the second was the qualitative method. Qualitative method is just by eyeballing. It is not necessary that we need to calculate the measurements every time. Once we start doing for every patient, just by eyeballing also, we will be able to see if the diaphragm is dysfunctional or not. So if we compare these two diagrams, the first one, obviously the diaphragm movement is much less compared to the second one. But for this eyeballing, we have to do frequent assessment, only then the interpretation will be correct. Again, here it is very clear that the diaphragm function is very good in this because the movement is so good. Just by eyeballing, also we can assess the function of the diaphragm. And also we can get to know about the paradoxical movement of the diaphragm. During inspiration, if the diaphragm is moving up, then we call it as a paradoxical movement. Clinically, it is anyways evident. If we have to document, it can be documented. So thickness can also be by eyeballing compared. Here the thickness is good. Here again it is reduced. So just by eyeballing also we can get to know that the thickness is reduced. This will happen if we more frequently do the diaphragm ultrasound. Then other difficult methods to assess the diaphragm function are putting an esophageal catheter with multiple electrodes and seeing the electromyography activity, electrical activity of the diaphragm. And the amplitude of the electrical activity of the diaphragm can be seen, and this can be measured. Coming to management and prevention, we have to go for something called as diaphragm protective ventilation, and diaphragm neurostimulation is again one more thing which can be used to reduce the diaphragm dysfunction. Along with this, the most important thing is to improve nutrition and address the underlying disease process for the management of diaphragm dysfunction. This is a slide which summarizes the diaphragm protective ventilation. What do we mean by diaphragm protective ventilation? First, we have to reduce the diaphragm inactivity. How can we do this? We should try daily to put the patient on a patient-triggered breath. Like we should try to keep the sedation and opioids as minimal as possible. And every day we should try to put the patient on a pressure support ventilation if possible, because whenever the patient-triggered breath happens, the diaphragm activity begins and the diaphragm dysfunction can be avoided. And once we put on the pressure support ventilation, it is important we see and monitor the respiratory effort also. If the patient's respiratory effort is very high on a pressure support ventilation, again it is going to lead to diaphragm dysfunction. So it is important we monitor the respiratory effort. Respiratory effort, clinically there should not be any activation of the accessory muscles. Patient should be hemodynamically stable, monitors heart rate, the other parameters should be good, the ABG parameters should be good. And along with this, some objective parameters like the P.1 occlusion pressure and the variation in the esophageal pressure can also be monitored. And accordingly, if there is increased respiratory effort, other maneuvers like adjusting the flow, inspiratory pressure, rise time, adjusting the sedation, FIO to PEEP, all these maneuvers have to be tried to make sure the respiratory effort is not very high. And along with this, we should also see that the ventilator and the patient asynchrony is kept to as minimum as possible, because that can also lead to diaphragm dysfunction. A small note on phrenic nerve stimulation. There are several studies that are coming up to avoid diaphragm dysfunction based on the phrenic nerve stimulation. The evidence for phrenic nerve stimulation is very strong in patients with spinal cord injuries, but for diaphragm stimulation, there are many studies for and against. So it depends on if your hospital has this phrenic nerve stimulation instrument and how well acquainted we are with using this. I have never used this phrenic nerve stimulation. This phrenic nerve stimulation can be broadly classified into invasive and non-invasive method. In invasive method, one is placing a pacemaker directly in the diaphragm and stimulating the diaphragm. If we anticipate that the patient is expected to stay in a controlled mode of ventilation for a very long time, then a pacemaker can be placed in the diaphragm to activate the contractile function of the diaphragm. And minimally invasive is transvenous or transcutaneous placement of a pacemaker. In non-invasive method, it can be divided into electrical and electromagnetic ways. Again, in electrical and electrical, these are the different ways in which you stimulate the peripheral this phrenic nerve to stimulate the diaphragm. To summarize, we have seen what is ventilator-induced diaphragm dysfunction. We have seen what is the pathogenesis of in which the diaphragm dysfunction happens. We have seen the assessment of the diaphragm function in bedside. We have seen what is a diaphragm protective ventilation, and we have also seen a short description on phrenic nerve stimulation. Thank you. Thank you, sir.
Thank you, Dr. Divya, for the excellent presentation. So that's the thing. So see, that ventilator-induced diaphragmatic dysfunction, one very interesting thing is basically it's time dependent actually, because it has been shown that in even after 12 hours, some of the studies have shown that as early as 12 hours, there is this diaphragm dysfunction is evident. And maybe in 24 hours time, at least, at least around 20-25% of the people will maybe, the patients on ventilator will be having the diaphragmatic dysfunction. And coming to the thickness also, maybe it can decrease by 20% by 48 hours. Lots of statistics are there. And obviously the most important thing you need to differentially diagnose it from other causes of this neuromuscular failure. Obviously you can have dysarthria, ischemia, sepsis, shock, all these sort of things can also give us to it may not be just directly related to the ventilator-induced diaphragm dysfunction. And obviously, as you rightly mentioned, that there is some strategy called diaphragm protective ventilation is happening. So that is the way to go. The components, as much as possible, we can try to implement the thing. And obviously, an ultrasound is very useful. It's a very bedside tool, very useful bedside tool for diagnosis of an early diagnosis and monitoring of a diaphragmatic dysfunction. Dr. Raghavendra, you want to add anything?
No, sir. It has been more sort of exhaustive. Thanks, Dr. Divya, for such an excellent talk. And something called the minimally
And Dr.
invasive.
Divya, you mentioned about carbon dioxide removal. It's all purely, I believe, physiologically and just hypothetical, I presume.
Yes.
Even some of the diaphragmatic strategy will be that you try to reduce the carbon dioxide and all. It's all not very bedside and it's not very implicable. Your strategy is mentioning that hypoxia,
yes,
all
sir.
this sort of thing which is giving rise to this.
Yes, sir. In case because of asynchrony, like we are not able to ventilate properly, instead of increasing the pressure support, instead of increasing the burden on the diaphragm and the lung, ECOR can also be tried to remove the CO2 so that the pressure control can
be very complex, isn't it?
Definitely, sir.
Finally, all the trials there is no evidence it is not going to make a difference.
That is why I did not speak about it.
No, it's okay. I just
yeah.
Sir,
So
there is one
those
sort
things
of
are
thing
also
where there is one sort of a thing where there is something called as a chrono injury. We tend to increase the respiratory rate so as to reduce the carbon dioxide level. Okay, but that sort of increment in the respiratory rate may per se can cause
absolutely.
lung injury.
Decrease in respiratory, that's one thing. Yes, that's very interesting. Yeah, and maybe now and only it is claimed to be there, but obviously neurally adjusted ventilatory
Neural adjusted. In that, we can see the esophageal pressure deflections, the transdiaphragmatic pressure deflections. All those can be monitored. Basically, we monitor the respiratory effort of the patient. If the respiratory effort is going to be high, then again it can lead to diaphragm dysfunction. So that is what they try to monitor in the neurally assisted ventilation.
Anyway, it's happy to notice the science is progressing very rapidly. Yeah. How they are going to be useful at the bedside, we need to wait and see what's happening. Yeah. Thank you, Dr.
Thank you,
Divya.
sir. Thank you, sir.
Thank you,
Thanks
sir.
a lot for your time, sir. Thanks a lot for your this thing.
Thank you,
for
sir.
giving me an
Thank you.
opportunity. Thank you.
Yeah,
Thank you, sir. Thanks a lot.
Bye.
We'll wind up the meeting. Thanks a lot.
Yes, thank you.